Good morning, everyone, and thank you for being here. Today we are covering the 2026 ACC AHA guidelines on the management of dyslipidemia, the most comprehensive, up-to-date to lipid management in nearly a decade. This guideline retires and replaces the 2018 blood cholesterol guidelines. The title changes alone from blood cholesterol to dyslipidemia signals a fundamental extension in scope. We are no longer managing a single number. We are managing atherogenic lipoproteins across the lifespan. In the next minutes, I will talk you through a very major changes, what it means in clinical practice, and exactly what you need to do different starting this week. Important disclaimer before we begin: this presentation is for educational and teaching purpose only. It does not constitute medical advice, and all clinical decisions must be based on individualized patients' evaluation and professional judgment. The full guideline is freely available at Circulation website, and I encourage you to read the primary source. Why a new guideline? The 2026 guideline was driven by four major cardiovascular outcome trials published after 2018. Fourier and Odyssey outcomes established the cardiovascular benefit of PCSK9 monoclonal antibodies. Clear outcomes validated bempedoic acid in statin intolerant patients, reduced it, demonstrated that ethyl reduced MACE in high-risk patients with elevated triglycerides on statins. Beyond those trials, we now have a new drug class, inclisiran, a small interferon RNA targeting PCSK9, olezarsen, an antisense oligonucleotide inhibiting ApoC3 for familial chylomicronemia syndrome, and binakumab, an ANGPTL3 inhibitor for homozygous FH. The scope expanded to formally address triglycerides, lipoprotein A, and non-HDL cholesterol alongside LDL cholesterol. 6 major patient management groups are defined. Primary prevention with LDL cholesterol 70 to 189. Severe hypercholesterolemia with LDL 190 or above, diabetes, clinical ASCVD, subclinical atherosclerosis, and hypertriglyceridemia. The class of recommendation system is unchanged. Core 1 means the intervention is recommended. Core 2A means it is reasonable. Core 2B means it may be considered. And Core 3 means it is not recommended or may cause harm. Top 10 home messages. Let me give you the 10 headlines before we walk through the evidence. 1. Treat dyslipidemia earlier. Cumulative lifelong exposure to atherogenic lipoprotein drives ASCVD risk. Lifestyle counseling should start in youth, and pharmacotherapy should be considered in young adults with familial hypercholesterolemia or LDL of 160 or above. 2. Use the AHA prevent equations, not the pool cohort equations. For 10 years and 30 years risk estimation, apply the CPR model, calculate risk, personalize using risk enhancers, and reclassify with coronary artery calcium when the decision remains uncertain. 3. Lipid lowering therapy may be considered at 10-year risk as low as 3% and should be considered at 5 to 10%. Number 4. LDL and non-HDL treatment goals are back. Percentage LDL reduction remains important, but absolute goals are now explicitly required. Number 5. ApoLipoprotein B is useful for identifying residual risk, particularly in patients with ASCVD, CKM syndrome, diabetes, or elevated triglycerides once LDL and non-HDL goals are met. Number 6. Lipoprotein A should be measured at least once in all adults. This is now a core 1 recommendation. Number 7, coronary artery calcium scoring in men 40 and older and women 45 and older provides multiple new core 1 guidance points for treatment initiation and goals. Number 8, lipid-lowering therapy is recommended for primary prevention in adults 40 to 75 with diabetes, CKD stage 3 to 4, or HIV, regardless of LDL-C level. Number 9, in secondary prevention, the LDL goal is below 55 for very high-risk patients. The majority of patients with established ASCVD will qualify for this tier. Number 10, statins remain the foundation for triglyceride management. Olezarsen is now core 1 for familial chylomicronemia syndrome. PCSK9 monoclonal antibodies are recommended for patients with ACVD and elevated lipoprotein A not a goal. Screening in children and adults. In adults, screening with a lipid profile is recommended beginning at age 19 and at least every 5 years thereafter. More frequent screening is indicated in individuals with additional cardiovascular risk factors. In children 9 to 11 years of age, not previously tested, a screening with a lipid profile is recommended to identify familial hypercholesterolemia and other significant lipid disorders. Core 2A. In individuals with first or second degree relative with premature ASCVD, severe hypercholesterolemia, or familial hypercholesterolemia, cascade screening starting at age 2 years or older is reasonable. Approximately 25% of the U.S. adults have an LDL of 130 or above. HeFH affects 1 in 250 to 300 individuals, and up to 90% are undiagnosed. Childhood lipid levels predict subclinical atherosclerosis and adult cardiovascular disease. Familial history alone is not sufficient. Up to half of all children with high LDL have no reported family history of hypercholesterolemia. Screening at age 9 to 11 is the optimal window because subclinical atherosclerosis can be detected as early as age 8 to 10, and cholesterol levels falls 10 to 20% during mid to late puberty before rising to adult levels. In children, either a non-fasting total cholesterol and HDL to calculate non-HDL or a fasting lipid profile is acceptable. ApoB is now part of routine pediatric lipid screening. Lipid measurement. The key changes. Core 1. In adult and children, a standard non-fasting or fasting lipid profile is recommended to document baseline lipid levels, estimate ASCVD risk, and guide initiation of lipid-lowering therapy. Core 1. In adults and children who have undergone a standard lipid profile use of either the Martin-Hopkins equation or the Sampson-NIH equation is preferred over the Fredwald equation to estimate LDL. Both are also preferred over direct LDL measurement, except for beta quantification. The Fredwald equation is inaccurate when triglycerides are 150 or above. LDL is below 70 or non-HDL is below 100. These are precisely the patients in whom accurate LDL estimation matters most. Core 1. Non-HDL should be routinely reported as part of the every standard lipid profile is calculated as total cholesterol minus HDL. Captures all atherogenic lipoproteins, including very low VLDL and IDL and lipoprotein A, and is better predictor of cardiovascular risk than LDL alone. Core 2A. In adults in lipid-lowering therapy, particularly those with ASCVD, CKM syndrome, type 2 diabetes, or elevated triglycerides, measures of ApoB is reasonable to guide decision regarding further therapeutic intensification once LDL-C and non-HDL-C goals are achieved. Routine advances in lipoprotein testing such as NMR, spectroscopy, gradient gel electrophoresis, or density ultracentrifugation is not recommended to estimate ACVD risk or guide initiation of lipid-lowering therapy. These tests do not meaningfully reclassify risk beyond a standard lipid panel combined with ApoB and lipoprotein A. Lipoprotein A measured once in all adults. In all adults, measure of lipoprotein A concentration is recommended at least once for ACVD risk and assessment. In individuals with FAH, premature ACVD, or high lipoprotein A, cascade testing of a first-degree family member is recommended to identify those at increased ACVD risk. Use laboratories with assays that are insensitive to apolipoproteins, isoforms, and traceable to official reference standard materials. Lipoprotein A concentrations are approximately 90% genetically determined by the LPA gene. They are largely stable over the lifetime and do not respond meaningfully to standard lipid-lowering therapy, including statins. And lipoprotein concentration of 125 nmoles per liter or above, equivalent to approximately 50 milligrams per deciliter, is a risk enhancer and is associated with approximately a 1.4-fold increase in ACVD risk. Values of 250 or above are associated with twofold or greater increased risk. The presence of elevated lipoprotein A is an indication for more intensified LDL-C lowering and aggressive management of all modifiable cardiovascular risk factors. In individuals with clinical ASCVD and elevated lipoprotein A who have not achieved LDL-C and non-HDL treatment goals of maximal tolerated statin therapy, addition of PCSK9 monoclonal antibody with proven cardiovascular benefit is recommended. Lipoprotein A varies significantly by ancestry and are highest in individuals of African ancestry. Universal screening ensures this population is not systematically undertreated. Lipid monitoring and follow-up. After initiating or modifying lipid-lowering therapy, a fasting lipid panel should be repeated at 4 to 12 weeks to confirm adequate LDL-C reduction and assess tolerability. If the LDL goal has not been achieved at this visit, a repeat panel and clinical assessment should occur at 3 to 6 months to determine whether therapy intensity should be increased or a non-statin agent added. Once the patient is stable on therapy and at goal, lipid monitoring every 6 to 12 months is appropriate and confirm ongoing goal attainment and adherence. If a statin-attributed muscle symptoms are present, creatine kinase, TSH, and repeat lipid panel should be checked. Hypothyroidism is a common and treatable cause of statin-attributed muscle symptoms. Lipoprotein A does not need to be rechecked after the initial measurement. One measurement provides a lifelong risk estimate. The goal of monitoring are confirming adequate percentage LDL-C reduction, verify achievement of the absolute LDL and non-HDL goals, assess adherence and tolerability, and determine whether non-statin add-on therapy is indicated. Prevent equations, replace pooled cohort equations. Core 1. In adult, age 30 to 79, without ASCVD or subclinical atherosclerosis and with an LDL between 72 and 189, the prevent ASCVD equation should be used to estimate the 10-year ASCVD risk with categorization as low, below 3%, borderline 3 to less than 5%, intermediate 5 to less than 10%, or high 10% or above. The prevent equations were derived from 3.3 million contemporary U.S. adults and validated in a separate cohort of 3.3 million. They provide risk estimate that are approximately 40 to 50% lower than those of the pooled cohort equation for the same risk factor profile, reflecting more accurate calibration in contemporary patients. Unlike the PCE, PREVENT does not use race or ethnicity as a predictor variable. Includes kidney function via GFR stat at age 30, provides 30 years risk estimate, and optionally incorporates hemoglobin A1C, urine albumin to creatinine ratio, and ZIP, zip code based social deprivation index. The CPR model structures how to use this risk estimate. C, calculate the 10-year ACVD risk using PREVENT P, which stands for personalized, the estimate using factors not captured by the equation, including lipoprotein A, high sensitivity CRP, family history of FH, reproductive risk markers, ethnicity, and social determinants of health. R, reclassify with coronary artery calcium scoring when the treatment decision remains uncertain after personalization. The 10-year risk threshold that guide treatment decisions are: below 3% is low risk, lifestyle constantly is the primary intervention, 3 to less than 5% is the borderline, lipid lowering therapy may be considered after a clinician patient discussion, 5 to less than 10% is intermediate, at least moderate intensity statin therapy is recommended, and a 10% or above high risk, high intensity statin therapy is recommended. PREVENT versus pooled cohort equation, key differences. The pooled cohort equations were derived from approximately 25,000 individuals from older birth cohorts with different lifestyle exposure to cardiovascular risk factors. Multiple validation studies demonstrate that the PCE of pooled cohort equations systematically overestimate 10-year ASCVD risk by 40 to 50% in contemporary U.S. adults. The PREVENT equation correct for this overestimation. Key structural differences include derivation in 3.3 million contemporary patients, a lower age limit of 30 instead of 40, race and ethnicity removed as predictor variables, inclusion of GFR to capture kidney function provides of a 30-year risk estimate in addition to 10 years estimate, and prediction of heart failure and total CVD outcomes alongside heart ASCVD. The removal of race and ethnicity from PREVENT equation reflects that these are social constructs rather than biological variables, and that structural and socioeconomic factors better captured by the optional social deprivation index are the underlying drivers. Because PREVENT estimates are approximately 40 to 50% lower than pooled cohort equation estimates for the same patient, the threshold for treatment consideration have been adjusted accordingly. The panel used the same methodology for selecting net benefit threshold that was applied in prior ACC and AHA guidelines. Risk enhancers and reproductive risk markers. Risk enhancers are clinical and laboratory factors that increase an individual's actual ASCVD risk above what the PREVENT equation calculates. They are used in the personalized step of the CPR framework, particularly in borderline and lower intermediate risk patients where the treatment decision is uncertain. Established risk enhancers include a family history of premature ASCVD, men below 55, women below 65, or HeFH, LDL 160 or above persistently, or non-HDL of 190 or above, lipoprotein A of 125 or above, high sensitivity CRP of 2 or above on 2 successive occasions without an identifiable underlying cause, metabolic syndrome or CKM syndrome, chronic kidney disease with eGFR 15 to 59, chronic inflammatory disease including rheumatoid arthritis, SLE, and psoriasis, and ankle breakout index below 0.9. Cohort 2 in adults without ASCVD with borderline 10-year risk of 3 to less than 5%. Consideration of risk enhancers is reasonable to personalized risk assessment and the potential benefit of initiation lipid lowering therapy. Cohort 2A, new in 2026 in adults with ASCVD without ASCVD. Consideration of reproductive risk marker is reasonable to personalize ACVD risk assessment when considering the potential benefit of initiating lipid lowering therapy. Reproductive risk markers include early menopause before age 45, history of adverse pregnancy outcomes including gestational hypertension, preeclampsia, gestational diabetes, and preterm delivery. These reproductive risk markers are independent predictors of future ACVD and should shift the treatment decision towards initiating lipid lowering therapy in women who are otherwise at borderline or lower intermediate risk. Coronary artery calcium guided treatment decisions. Cohort 1 in adults at intermediate risk and selected adults at borderline risk with no prior ACVD. If the decision regarding lipid lowering therapy remains uncertain, a calcium score should be used to further risk stratify and to guide the decision to withhold, postpone, or initiate therapy. In Cohort 2A, if the calcium score is 0 units and there is no higher risk condition defined as FH, severe hypercholesterolemia 190 or above, diabetes plus age over 40, current cigarette smoking, or a strong family history of premature ASCVD, it is reasonable to defer therapy and reassess with repeat calcium score testing in 3 to 7 years. Cohort 1, if the calcium score is greater than 0 Agaston, it is recommended to initiate lipid lowering therapy, particularly if the calcium score is 100 or above, or at or above the 75 standardized percentile. For a calcium score of 1 to 99, below the 75th percentile, moderate intensity statin is reasonable with the LDL cholesterol goal below 100 and non-HDL below 130. For calcium score between 100 to 299 or above the 75th percentile, statin therapy is recommended to achieve at least 50% LDL-C reduction and a goal of LDL-C below 70 and non-HDL below 100. For a calcium score between 300 to 999, high-intensity statin with LDL-C goal below 70, it is reasonable to intensify with Zetia, PCSK9 inhibitor, or bempedoic acid to reach a goal LDL below 55 and a non-HDL below 85. For a calcium score 1000 or above, Cohort 1, treat the LDL lowering therapies to achieve at least 50% LDL-C reduction and a goal of LDL below 55 and a non-HDL below 85. In adult with no prior SCVD, if incidental calcium score is identified and a non-cardiac CT scan, whether by visual estimation or validated AI-based algorithm, the presence of a coronary atherosclerosis should be considered during decision-making above initiation or intensification of lipid-lowering therapy. Statin therapy. Intensify classification. Statins remain the recommended first-line drug class for lowering lipid therapy in all risk categories. High-intensity statin therapy is expected to lower LDL by 50% or more. The preferred agents are atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. High-intensity therapy is indicated for secondary preventions in all ASCVD patients with primary prevention a higher 10-year risk of 10% or above, or LDL of 190 or above, diabetes with multiple ACVD risk factors, and a calcium score of 1000 or above. As far as a moderate intensity statin therapy is expected to lower LDL by 30 to 49%. Options include atorvastatin with a dose 10 to 20, rosuvastatin 5 to 10 milligrams, simvastatin 20 to 40, pravastatin 40 milligrams, and pitavastatin 1 to 4 milligrams. Moderate intensity therapy is indicated for diabetes 40 to 75 years without established ACVD, intermediate risk primary prevention, borderline risk primary prevention when a treatment decision is made, and a calcium score 1 to 99. Low intensity statin therapy is expected to lower LDL by less than 30% and should be used only when higher intensities are not tolerated. It is not the preferred initial strategy for any risk group. In addition to percent LDL reduction, an absolute achieved LDL level is now explicitly required as a treatment objective. Both the percentage reduction and the absolute goal must be met. Certain populations, particularly those of East Asian ancestry, may be more susceptible to side effects due to inherited pharmacokinetic differences. Initial treatment in this group should begin with lower doses. Simvastatin 80 milligrams carry an FDA black box warning for myopathy, including rhabdomyolysis, and should not be initiated or titrated to 80 milligrams. Statin pharmacokinetic properties. This table summarizes clinical relevant pharmacokinetic difference across statins. 3 patterns have direct clinical implication. Atorvastatin, lovastatin, and simvastatin are metabolized by CYP3A4. Co-administration with strong CYP3A inhibitors include azole antifungal, clarithromycin, HIV protease inhibitors, and cyclosporine. Significantly increased statin plasma concentration and myopathy risk. In patients on cyclosporine, pravastatin is the preferred statin due to minimal CYP metabolism. Rosuvastatin and fluvastatin are metabolized primarily by CYP2C9. They have fewer interactions than CYP3A4 statin and are preferred in patients with CYP3A4 interactive medications. Pravastatin has no significant CYP metabolism, is hydrophilic with low tissue penetration, and has the fewest drug-drug interaction. It is the preferred agent in high DDI risk patients, including transplant recipients and many HIV patients. Rosuvastatin has the longest half-life at 19 hours, providing consistent steady-state LDL lowering. Dose reduction is recommended in patients of Asian ancestry. Gemfibrozil must never be combined with any statin due to serious myopathy and rhabdomyolysis risk for multiple pharmacokinetic interaction mechanisms. Fenofibrate or fenofibric acid should be used instead when a fibrate and statins are both indicated. Non-statin LDL lowering therapies. Zetia inhibits intestinal cholesterol absorption via the MPC1L1. It lowers LDL by approximately 18% as monotherapy and by 25% when added to a statin. It is an oral, genetic, low cost, and well tolerated. The improved trial demonstrated a reduction in cardiovascular events with Zetia was added to simvastatin versus simvastatin alone in ACS patients. Zetia, ezetimibe, is the recommended first add-on agent when a statin monotherapy does not achieve an LDL goal. PCSK9 monoclonal antibodies, evolucumab and alirocumab, block PCSK9, increases LDL receptor recycling and hepatic LDL clearance. They lower LDL by 45 to 64%. Fourier demonstrated that evolocumab reduced MACE in patients with established ACVD on statin therapy. Odyssey outcomes show alirocumab reduced MACE and total mortality in post-ACS patients. Both agents are administered subcutaneously every 2 to 4 weeks depending on the agent and indication. Inclisiran is a small interferon RNA that silences hepatic PCSK9 messenger production. It lowers LDL by 48 to 52%. It is administered subcutaneously at a baseline at 3 months and then every 6 months. Cardiovascular outcome trials are currently in progress. Inclisiran is currently recommended based on LDL-C lowering efficacy as a surrogate endpoint. Bempedoic acid inhibits ATP citrate lyase, an enzyme in the hepatic cholesterol synthesis pathway upstream of the site where statins act. Critically, it is not activated in skeletal muscle, which means it does not cause the muscle-related adverse effects seen on statin. It lowers LDL by 21 to 24% as monotherapy and by 17 to 18% when added to statin. The CLEAR Outcomes trial demonstrated a reduction in cardiovascular events in statin-intolerant patients at high cardiovascular risk. Non-statin therapies are substantially underutilized due to clinical inertia, misconception that only statin reduce ACVD risk, access barrier for branded products, and unfounded concerns about side effects. Combination non-statin therapy with a low or moderate intensity statin can produce LDL-C reduction equivalent to high intensity statin therapies. Common statin drug interaction. Gemfibrozil must never be combined with any statin. The combination dramatically increased statin plasma level through multiple mechanisms, including inhibition of the hepatic uptake, transporting, and glucuronidation, resulting in serious risk of myopathy and rhabdomyolysis. Fenofibrate or fenofibric acid should be used instead when a fibrate is required alongside statin therapy. For all other agents on this table, the recommended approach is to identify the statin primary metabolic pathway and then apply 1 or 3 risk mitigation strategies. Avoid the interaction drug. Switch to a statin not subject to that interaction or limit the statin dose according to a specific interaction profile. Commonly encountered interactions require attention include amiodarone with simvastatin and lovastatin. Limit the dose. Clarithromycin and erythromycin with CYP3A4 metabolized statins. Consider temporary halt or dose reduction. Cyclosporin. Switch to pravastatin. HIV protease inhibitor contain ritonavir or covicistat. Use pravastatin or rosuvastatin at low dose. Diltiazem and verapamil. Limit simvastatin to 10 mg. A clinical decision support tool for statin drug interaction management is available at the ACC Lipid Manager application. Secondary prevention. LDL-C goals. Very high risk is defined as 2 or more major ACVD events, which include ACS within the past 12 months, history of myocardial infarction, history of ischemic stroke, and symptomatic peripheral artery disease, or 1 major ACVD event plus 2 or more high-risk features. High-risk features are age 65 or older, prior coronary bypass or percutaneous coronary intervention, current smoker, diabetes, history of heart failure, hypertension, and LDL of 100 or above despite maximal tolerated statin plus Zetia. Core 1. In adults with clinical ACVD who are not very high risk, high-intensity statin therapy should be initiated to achieve at least 50% reduction in LDL and go LDL below 70 and non-HDL below 100. In adults with clinical ACVD who are not at very high risk and are maximal tolerated statin therapy, it's reasonable to add SETIA, a PCSK9 monoclonal antibody, or bempedoic acid to achieve a goal LDL below 55 and a non-HDL below 85. In adults with clinical ACVD who are at very high risk and some maximal tolerated statin therapy, SETIA or PCSK9 monoclonal antibodies should be added to achieve a goal of LDL 55 and non-HDL below 85. In adults with very high risk of maximal tolerated statin, it is reasonable to add bempedoic acid with a SETIA and PCSK9 monoclonal antibody to reach. Inclisiran is reasonable in very high risk patients unable to tolerate or attain evolocumab or alirocumab, or whom have strong preference to less frequent dosing. In individuals with clinical ACVD and elevated lipoprotein, non-LDL and non-HDL goal of maximal tolerated statin therapy, additional PCS monoclonal antibody with proven cardiovascular benefit is recommended. Primary prevention. Decisions in adults 30 to 79 years of age without prior ACVD and with LDL between 70 to 189 begin with the 10-year ACVD risk estimator using the PREVENT equations. For a low risk, below 3% in adults with LDL-C below 160 and a 30-year risk below 10% for those aged 30 to 59, counseling on health behaviors is recommended. In adults with LDL-C of 160 to 189 or 30-year risk 10% or above, a moderate intensity statin is reasonable. For borderline risk, 3 to 5%, moderate intensity statin is reasonable in patients in whom decision to initiate statin therapies may target at least 30 to 49% LDL-C reduction and a goal of LDL below 100 and non-HDL below 130. For intermediate risk, 5 to less than 10%, at least a moderate intensity statin is recommended to achieve 30 to 49% LDL-C reduction. For patients at the higher end of this range, high intensity statin is beneficial to further reduce LDL by 50% or more. The LDL goal is below 100 or below 70 if high intensity therapy is used. For high risk, 10% or above, high intensity statin therapy is recommended to achieve at least 50% LDL reduction. The goal is LDL below 70 and non-HDL below 100. SETIA should be added if LDL goal below 70 is not achieved or maximal tolerated. In all individuals with dyslipidemia, clinicians and patients should engage in individualized benefit-risk discussion covering ACVD risk, health, lifestyle as the foundational treatment, expected risk reduction benefit from lipid-lowering therapy, potential harms and drug interaction, cost, and patient's preference. Severe hypercholesterolemia. LDL greater or equal to 190. In individuals with HeFH, standard risk assessment tools developed for the general population include PREVENT should not be used to calculate 10 years or 30 years ACVD risk. These tools underestimate lifetime risk in FH patients. In adults with severe hypercholesterolemia with LDL of 190 or above and without clinical ACVD, additional ACVD risk factors, HeFH or subclinical atherosclerosis, who are maximal tolerated statin therapy, additional SETIA or PCSK9 monoclonal antibody and or bempedoic acid is recommended to achieve a goal of LDLs below 100 and non-HDL-C below 130. Core 1. In adults with severe hypercholesterolemia and LDL 190 or above without clinical ACVD but with a clinical genetic confirmation of additional risk factors to documented coronary calcification, addition of SETIA, PCSK9, and bempedoic acid to maximal tolerated statin is recommended to achieve a goal of LDL below 70. Diabetes without established ACBD. In adults 40 to 75 years of age with diabetes and without clinical ACBD, moderate intensity therapy is indicated to achieve 30 to 49 reduction in LDL-C and a goal of LDL below 100 and non-HDL below 130. This is a revision from the 2026 guidelines adds explicit absolute LDL-C and non-HDL-C goals in addition to the percentage reduction target. Both must be met. Hypertriglyceridemia. Below 150 are normal. Triglycerides 150 to 499 represents mild to moderate hypertriglyceridemia, and the primary concern in ACBD risk through triglyceride-rich remnant particles. Triglyceride 500 to 999 represents severe hypertriglyceridemia with dual concerns for both ACBD and pancreatitis. Triglycerides of 1000 or above represents very severe hypertriglyceridemia with acute pancreatitis as a dominant clinical risk factor. In adults with clinical ACBD and LDL-C of 55 or above and non-HDL of 85 or above on maximal tolerated statin therapy with persistent elevated triglyceride 150 to 999, intensification of LDL lowering therapy is recommended to reduce ACBD risk. Statin therapies remain the foundation for pharmacotherapy and hypertriglyceridemia in the context of ACBD risk reduction. Fibrates and niacins are not recommended as a routine add-on agents to statins for ACBD prevention based on the absence of cardiovascular outcomes benefit in multiple trials. In adults with familial chylomicronemia syndrome, fasting triglycerides 1000 or above, olezarsen and lipoprotein C3 antisense oligonucleotide inhibitor is recommended as an adjunct to diet to lower triglycerides levels and reduce the risk for pancreatitis. In adults 40 to 75 without history of ACBD or diabetes who have persistent elevated triglycerides, it is recommended to estimate 10 years ACBD risk by preventing the question to guide the benefit-risk discussion regarding lifestyle optimization and potential initiation of statin therapy. In individuals with fasting triglycerides of 1000 or above, referral to a registered dietitian nutritionist is recommended to create an individualized treatment plan to reduce triglycerides and lower the risk of pancreatitis. Icosapentylethylene is a highly purified EPA-only prescription omega-3 formulation. It reduces triglycerides by 15 to 30% through multiple mechanisms, including reduction of hepatic VLDL triglyceride synthesis. The reduced IT trial demonstrated 25% relative risk reduction in MACE in patients with triglycerides 135 to 499 in statin therapy. It is administered 4 grams daily in 2 divided doses with food. Omega-3 acid ethyl esterases combine both EPA and DHA. They lower triglycerides by 20 to 30%, but have not demonstrated cardiovascular event reduction. The STRENGTH trial was stopped early for futility. DHA-containing formulations may modestly raise LDL. Over-the-counter fish oil supplements are not equivalent to prescription formulations and have not been evaluated in cardiovascular outcome trials. Fenofibrates and fenofivric acid stimulate PPAR-alpha, activating lipoprotein lipase and reducing triglycerides by 30 to 50%. They are first line for severe hypertriglyceridemia above 500 to reduce pancreatitis risk. They do not reduce ACBD events even when added to statin therapy. Gemfibrozil must never be combined with a statin. Olezarsen is an antisense oligonucleotide targeting apolipoprotein C3 messenger RNA, approved specifically for familial chylomicronemia syndrome. It reduced triglycerides by 42%. Placebo-corrected in the indication is administered as an 80 mg subcutaneous injection once monthly. Niacin reduces triglycerides by 20 to 40%, but is generally avoided due to high rates of flushing, hepatotoxicity, and insulin resistance. AIM high and HPS2 Thrive show no cardiovascular benefit when added to statin therapy. Special populations new recommendation. CKD stage 3 or higher with clinical ACBD, lipid-lowering therapy with high-intensity therapy, statins with or without SETIA, and PCSK9 monoclonal antibody is recommended to achieve at least 50% LDL reduction and a goal LDL 55 and non-HDL below 85. CKD stage 3 or higher without ACBD is recommended in adult 40 to 75 regardless of LDL levels for primary prevention. This is a new recommendation. People living with HIV age 40 to 75 on a stable combination of antiretrovirals. Statin therapy is recommended to reduce the risk of a first ACBD event and reduce the rate of coronary atherosclerosis progression. Drug-drug interaction with antiretroviral regimen must be carefully evaluated, particularly CYP3A4 interaction with protease inhibitors. Adult cancer survivor with a life expectancy of at least 2 years who otherwise qualify for lipid-lowering therapy should be treated in similar for patients without history of cancer to reduce the risk of ACBD events. Children and adolescents with FH panel-based genetic testing for pathogenic FH variants is useful to guide diagnosis, cascade testing, and treatment. Statin therapy is safe and effective in FH children. Pregnancy. Statins are contraindicated throughout pregnancy. In pregnant individuals with severe fasting hypercholesterolemia of 500 or above fibrates after the first trimester or high-dose omega-3 ethyl esterases are reasonable to lower triglycerides and reduce pancreatitis risk. Older adults above 75, lipid-lowering therapy can be considered in conjunction with lifestyle intervention. Treatment decisions should be individualized based on comorbidities, life expectancy, and patient's preference. Heart failure without concomitant ACBD. Statins do not improve mortality or hospitalization rates in heart failure with reduced ejection fraction as demonstrated in Corona and GC heart failure in patients with heart failure who have established ACBD. Treat underlying ACBD per secondary prevention guidelines. Metabolic dysfunction associated steatotic liver disease. Statins are safe in MAS LD, do not cause clinical significant liver injury. Transaminase elevation in these patients reflect the underlying liver disease, not statin hepatotoxicity. The statins are not contraindicated and may reduce liver fibrosis. Chronic inflammation disease, including rheumatoid arthritis, systemic lupus erythematosus, and psoriasis, are risk enhancers that warrant lower treatment threshold and early initiation of lipid-lowering therapy. Acute coronary syndrome, high-intensity statin therapy should be initiated or confirmed prior to hospital discharge. If LDL is above 55, a maximum tolerated statin, SETIA should be added. For very high-risk ACS patients, not a goal of early PCSK9 inhibitor initiation with 1 to 2 weeks post-ACS is reasonable. A statin-attributed muscle symptom management includes dose reduction, alternate day dosing, and switching to less lipophilic statins such as pravastatin or fluvastatin. Bempedoic acid is the preferred non-statin alternative for patients with statin-attributed muscle syndrome as it is not activated in skeletal muscle. TSA should always be checked to exclude hypothyroidism as a contributing factor. Lifestyle management encompasses assessment of and counseling of heart healthy eating patterns, regular physical activity, avoidance of all nicotine-delivered products, healthy sleeping habits, and maintaining healthy weight. It is forms the foundational treatment of every patient category and should be initiated before alongside pharmacotherapy. Dietary patterns with stronger evidence of LDL and triglyceride lowering includes Mediterranean, Dutch, and plant-based diet. These patterns emphasize reduced saturated fat, trans fat, refined carbohydrates, and added sugar, while increasing fiber, whole grains, vegetables, legumes, and omega-3 rich foods. At least 150 minutes per week of moderate intensity aerobic exercise or 75 minutes of vigorous aerobic exercise is recommended, combined with resistance training twice weekly. Aerobic exercise lowered triglycerides by 10 to 30% and raised HDL by 5 to 10%. Modest weight loss of 5 to 10% improved triglycerides, HDL, and LDL particle size. GLP-1 receptor agonists have favorable effects on lipid profile and should be considered in an appropriate patient with obesity or type 2 diabetes. In individuals with dyslipidemia, the use of dietary supplements, including fish oil supplement, regicide, garlic, and plant sterol, is not recommended to lower LDL or triglyceride based on limited or inconsistent data. In individuals with fasting triglyceride of 1,000 or above, referral to a registered dietitian nutrition is recommended. When to refer to a clinical lipid specialist is indicated in the following settings: for familial hypercholesterolemia, all patients with homozygous FH, patients with heterozygous FH not achieving LDL goals on maximum tolerated statin plus non-statin, patients with heterozygous FH with statin attributed side effects on 2 or more statins at the lower dose. For high-risk ACVD with the met goals, patients not achieving at least 15% LDL reduction and LDLs and under target of maximal tolerated statin plus non-statin therapy. With onset before age 30. Elevated lipoprotein of 200 or above, patients with statin attributed side effects. For complex comorbidities, patients receiving treatment for HIV, patient receiving cancer treatment with complex drug interaction, patient receiving immunosuppressive regimen for transplant individuals planning pregnancy or pregnant with FH or severe hypercholesterolemia. The individualized benefit risk in individualized with dyslipidemia. Clinicians and their patients should engage in a discussion of the patient ACVD risk, healthy lifespan as a foundational risk reduction. Expect risk reduction benefit from lipid lowering therapy, possible harm and drug interaction costs, and patient preference to make individualized treatment decision. The 5 components in the discussions are ACVD risk assessment, calculate and communicate the 10-year and 30-year risk using PREVENT. Using both absolute and relative terms, emphasize on healthy lifestyle habits and the treatment foundation, the potential net clinical benefit of pharmacotherapy. Include both absolute risk reduction and potential adverse effect. Cost convenience consideration include route and administration dose. This table summarizes the LDL and non-HDL goals for every major risk category addressed in 2026 guidelines. Very high risk ASCVD, LDL below 55, non-HDL below 85, at least 50% LDL reduction with a high intensity statin plus non-statin therapy. ACVD not at very high risk, LDL below 70 or non-HDL below 100, at least 50% reduction with high intensity statin. Primary prevention, high risk of 10-year or above, LDL below 70 or non-HDL below 100. Primary prevention, intermediate, 5 to 10%, LDL go 100 and non-HDL 130. Primary prevention, borderline risk, LDL below 100, non-HDL below 130. Diabetes, LDL below 100, non-HDL below 130. Diabetes with multiple risk factors, LDL below 70 and non-HDL below 100. Severe hypercholesterolemia, LDL 190 or above without a CVD. Or FH, LDL below 100 with atherogenic FH or risk factors, LDLs below 70. Subclinical ACVD with a CASA score of 1 to 99. And LDL below 100 with moderate intensity, CASA score between 100 to 299, LDL below 70, statin with or without non-statin, calcium 1000 or above, LDL below 55, aggressive LTT therapy. These are the everything gap and future directions and these are the key clinical takeaway points.